I don't know which way you would prefer to have. You want to have the question answers simultaneously going on when the reactions are still live, or do you want to have discussion then simultaneously? Yeah? Okay. So in the last 2 days, you come across this information. You are well versed with this, because I am going to presume that you know what we are talking about. So what we are talking about in posterior uveitis is inflammation which are limited to retina, choroid, neuroretinitis, and there will be inflammations from retina going to the choroid, retinochoroiditis, and the other way around. The inflammation is in the choroid and it's affecting the retina. And of course, you can have retinal vessels inflamed also. So many of these pan-uveitis would have a component of posterior uveitis at some stage of the disease. So obviously I can't touch upon all, but I'll give you a glimpse of and ask you whether you have seen any of those. And this also I think you have seen. They've explained to you, because these are the descriptors. So whenever you see a patient of uveitis, you need to be able to describe it, whether it's acute, is it it's recurrent, what is the course of the disease, is it limited duration, is it chronic. So all of you know the definitions, I don't need to go. I'm just showing you this slide just to make sure that you understand that you need to describe. And I can tell you, till very recently, I didn't realize that our descriptive power is so poor. So if I asked you to describe to a blind person a horse and a donkey, so even a blind person who is not able to visualize that is able to tell that this guy is a horse, this guy is a donkey. So that should be our descriptive power when you are describing these. Because we don't describe, we have not learned to describe the pathology as we see, we make blunders. Okay? Having said that, I think Dr. Kwan was showing this slide, and here you can see these are, the first column is all infectious uveitis. The second column is where inflammations are associated with systemic diseases, and you would realize that barring tuberculosis, okay, we had so much discussion, probably majority of these are non-infectious. And then we have a third column. These are the kind of diseases which affect the posterior segment, about the origin of which we still don't know anything, very uncertain origin. And the current thinking is that many of these might be triggered by some obscure infections. So maybe during your lifetime, the third column might get merged with the first column. Now, why we need to have these three or two groups, broadly speaking, an infectious group and the non-infectious group, and Dr. Kwan was very, very elaborate trying to tell you the differences. Okay. I suggest to you, with few exceptions, retinitis is mostly infectious, and choroiditis is by and large non-infectious. Do you all agree with this statement? It's a very broad statement I have made. Any exceptions to this? Anyone?
Tuberculosis.
Yeah, tuberculosis, I said, is a mix of two. As of now, we understand TB to be an infective disease which produces pathology by its immune reactivity. On itself, if the TB bug was sitting somewhere, it will not be able to create any disease unless it causes by its immune reaction, inflammation and destruction, and that's because your immune system is trying to destroy this organism and the process destroys itself. So we'll not go into that because you had a lot of discussion. Now, why is it important to tell the difference whether it is retinitis or is it choroiditis? So you learned that retinitis is infectious, choroiditis is non-infectious. If you go with this dictum, okay, then we know if we make the other way, if we are not able to tell when we look at patient fundus whether we are dealing with retinitis or we are dealing with choroiditis, you will make disasters. I'll show you examples. Now you can all see this is a case of toxoplasmic retinochoroiditis. You can see a lot of here necrotizing lesion here. The vessels are obscured. There's a lot of exudation, the exudatory fluid. The patient is symptomatic because the fluid has now gone right up to the foveal center. So patient was symptomatic but still seeing about 6-9. And this patient has been seen by a very smart ophthalmologist who had access to a fundus camera, and he documented his own disaster. And how? He treated this patient thinking it's choroiditis, and somewhere our teachers had been teaching, at least my teachers used to teach, maybe your teachers don't teach that all inflammation in the retina, in the posterior segment, has to be treated with oral corticosteroids. Okay. Now, if you treated this patient with oral corticosteroids, not trying to tell the difference between retinitis and choroiditis, what do you expect to happen? Any guesses? You treat any infection with steroids, what will happen? Exacerbation, disaster, huh? Tsunami. Huh? Indonesia, you have some people from Indonesia? Huh? We are all with you in the hour of your grief. Okay? Don't live by the side of the sea. Huh? It hits back. So what do you think? How the tsunami came? This guy gave oral steroids. Didn't work. Patient's vision went down. So gave posterior subtenon triamcinolone. Didn't work. Then he gave intravitreal triamcinolone. It didn't work. What will happen? This is what happened. The patient, she's a young girl. There is a disaster which has happened. And no matter what we did at this stage, okay, you can't retrieve the vision. She came to the surgeon, ophthalmologist, 6-9 vision. She is left with common finger close to face. Okay, this happens. Just because he thought any inflammation needs to be treated with steroids. On the other hand, I think Dr. Amod Gupta was talking a lot about this disease. This is a gentleman whom we diagnosed as serpiginous-like choroiditis. His TB tests were positive, so he was initiated on anti-TB drugs, thinking that this pathology is infective. Okay, and forgetting the dictum that in the choroid, by and large, what you see is immune, non-infectious. Okay, if we had remembered that, we would have not treated with anti-TB drugs straight away. And this is what you see within 2 weeks, within 3 weeks, his fovea is now getting threatened, and by 4 weeks, it's come right close to the center. And this is the time when we wake up and, you know, we say, oh my God, this patient had been treated with corticosteroids. Because the predominant pathology may be because of the TB. The TB might have played a role in triggering this lesion. But it is manifested because of its immune reaction. So we have to, predominant picture is of an immune reaction, so it needs to be controlled with corticosteroids. So you have seen, understood now, if we treat retinitis with steroid, what will happen? If we treat choroiditis with antibiotics, what will happen? Okay? Now, who can tell me how do we treat toxoplasma these days? Yeah?
There are many different types of medications which you can use. It used to be the classic chemotherapy.
So can we have a mic or something? Roaring mic? So well, this is a patient of toxoplasma. You can see the left panel. Yeah, just give it. You have only one, or so give one on this side and one on the right wing and one in the left wing. So let's see. So this patient, earlier we used to treat them with pyrimethamine, you know, and sulfadiazine, and you know, sometimes we gave triple therapy including clindamycin. Okay, so many drugs were used which are either not available, and pyrimethamine, you know what does it do? Huh? You need to give folic acid. Yeah. So these are very toxic drugs. Clindamycin, what do you get when you give clindamycin to the patient orally? Pseudomembranous colitis, Clostridium difficile infection, which is fatal. Do you know how to treat that? Clostridium infection, how do they treat them these days? Anybody? I just want to check how aware are you about other aspects of medicine. Generally, you have to be aware about other aspects rather than focus on the ophthalmology or eye. Yeah? So these days Clostridium earlier used to be fatal. Okay. And now it's eminently treatable with stool transplant. Stools from healthy people are transplanted into the intestines, so they swallow with the capsules, repopulate the normal flora of the gut, and patients survive. Okay, so we'll not go into that. So this patient is treated. I mean, this background is important. Why I'm telling you this background? Tell me. Anybody would like to venture any thoughts? Why did I tell you this story on Clostridium?
This patient probably got treated.
No, it's nothing to do with this patient. Just so that when you will go home, you'll remember, of all the things, you will remember only that that guy talked of stool transplant for a Clostridium difficile infection or pseudomembranous colitis occurring because of clindamycin, so we should not be giving oral clindamycin. Okay, so what we have achieved here is giving 1 milligram clindamycin intravitreally once every week, compared to 1200 milligrams orally that we were giving for at least 6 weeks, compared to 1 milligram. So average is 1 to 2 injections it will take for these lesions to heal. As you can see here beautifully, the lesion is healed. So if you know that this is a retinitis and this is toxoplasmic retinitis, okay, or retinochoroiditis, I'll show you those examples. You can treat them very effectively and very efficiently. I'll not be telling the treatment parts because once you know the diagnosis, the challenge is pinpointing what is the diagnosis. Treatment you can always look up on the internet. I'm sure all of you have smartphones and you can, within seconds, you can know what is the current treatment for. So you would find for toxoplasma these days, intravitreal clindamycin is as good as they were using with the standard of care pyrimethamine, sulfamethoxyl, whatever. They're not even available. I've never prescribed a sulfatazine in my life in the last 45 years. Okay. Now, what is important to realize when you're looking, yeah, please.
Just to clarify, so you're saying that will be your first line treatment?
This is the first line treatment. Intravitreal clindamycin is the standard of care now. Okay, with dexamethasone. So you can give either the dexamethasone on the same day, 400 micrograms, or you can give it the next day. I'll be a little scared. You want to give prophylactic if the patient has multiple recurrences, say like 3 or more recurrences every year. Then like to give them Bactrim DS, you know Bactrim DS or Ceftriaxone DS double strength. Okay. So one would give them 1 tablet twice a week for as long. Okay. If it's a recurrent, too often it's recurrent, but otherwise you will not. You can treat them very simple by this. There's no way you can eliminate the cystic forms of toxoplasma from the body. So there is no rationale of giving systemic treatment, okay, for a local disease. Now, if you study this, so what you would find that there is a localized vitreous inflammation. We used to call it lamp in the fog, headlamp in the fog, when you're driving in foggy conditions. Okay, so you can see this, you are not seeing very clearly the margins because of the vitreous haze overlying, but rest of the retina is much clearer. Okay, then you look at the vessels which are coursing through the lesion, and you would realize that these are getting obscured. So as the vessels pass through, you are not able to make out the outline of the vessels, right? On the other hand, I am giving you now patient with multifocal choroiditis lesions. Okay, now what you see, the retinal vessels, you don't see as much haze. You might see some vitreous cells, but they will never be as many vitreous cells as you see in these focal necrotizing retinitis lesions. So here you might see some, I'm not saying that, you would see some, but they would not be localized over a particular lesion. Moreover, what you will see here, the retinal vessels are crossing over these lesions very nicely. There is no obscuration of the retinal vessels by these lesions for obvious reasons, because these lesions are lying in the choroid. Is that right? Clear? Any question on that? What else can you do to tell the difference between my entire this thing is today retinitis and choroiditis? What else can you do? Yeah, you're right. Yeah. So don't let it stay there. Speak out. You see, you must learn to put your neck on the block, as is. Okay. Nothing happens are not going to fall. Nothing is going to happen. You can at best be wrong. Who's going to hang you because you couldn't tell that FA should be done to tell the differences? Huh? There's no penalty for not knowing. But you have a good chance of being right, isn't it? And score points. So this is what I'm showing you now, the angiogram of retinitis. It's the same patient of toxoplasma retinitis. And what you can see here, when you inject the dye, there's a little bit of the vessels are also inflamed there. They're a little blurry. The margins are not distinct. Can you appreciate that? Okay. So when any of these vessels are passing through a retinitis, they will also get focally inflamed in that area. Toxoplasma, they could be inflamed. You could have what we call chirales deposits. Who was chirales? Why is it in use these days? After ages, this guy came into news because it turned out that he was a Nazi. So a lot of these, like Wagner's, Wagner was a Nazi. Okay, so what has been now renamed, Wagner's granulomatosis has been renamed as? Granulomatosis with polyangiitis. So world over, rheumatologists, they got together and they said, we are not going to remember Wagner because he was bloody butcher. He was not a scientist. So it turned out chirales, of the fame of chirales deposits on the arteries in patients with toxoplasma, was also Nazi. So there is move to drop his name also from all these pathologists. Okay, anyway, that's beside the point. These are side stories so that the information, which is the genuine, the real information, goes and sticks there by way of association. Because you are likely to remember the story, and along with the story you remember that little fact. So you can see intense staining of the retinitis in later frames. You can make out this very intense staining. So this is the retinitis. Now, what do you want to see next? Why don't you anticipate the next slide? ICG, we'll first talking about the fluorescein. You want to see the fluorescein of choroiditis, don't you? Isn't it? When we are comparing, so you want to see that. Now see the difference. There is a choroidal granuloma there. So what do we see? Here we are seeing these hypofluorescence. So any lesion in the choroid will produce initial hypofluorescence, and later on there is a staining. See the difference? It's practically the same size of lesion in the choroid and in the retina. See the difference in the staining pattern. Here the vessels are getting stained. The retinal tissue there is a leakage in the retinal tissue because of the inflammation, and the dye is impregnated in the retina and very intensely, and that's how you see this intense staining. And here it is stained. It is stained, no doubt, but it's an apology of a stain. Okay, unless it is more reactive when it will produce little bit of exudation. Okay. Are we clear so far? This is now, I am showing you the same patient. Okay. Now you are seeing the response to intravitreal clindamycin in this patient in the left panel. And what are we seeing here?
Resolution of the thickening.
This is the OCT scan. Okay, this is what we call structural OCT, what we used to call OCT in the previous era. Now with the availability of OCT angiography, you know, you want to tell the difference between a structural, where we are looking at the anatomical or the structural integrity, versus the functionality, okay, which we do with, earlier we used to do fluorescent angiography and ICG, and now OCT angiography. So here we are seeing the structural. So it should occur naturally to you that, well, if there is a lesion which I am not able to tell whether it's retinitis or choroiditis, why not put it on the OCT machine if you have access to that, and see that in this patient it's all the inner retina which is thickened, hyperreflective, and as the lesions heal, you can see that they keep on coming down. Okay, so I talked of a choroiditis lesion which I showed you earlier, this one, where the lesion, by looking at this picture, I would say this choroidal granuloma is not very reactive. It's a very little fluid, you can see here, make out, very little leakage, so it's not really highly reactive. So that reminds me of reactive granulomas and non-reactive granulomas. Where would you expect a non-reactive granuloma or relatively non-reactive? The reaction comes from our inflammatory response. Inflammatory response comes if you have intact CD4 T helper cells. If they are not there, what condition you have CD4 cells disappearing? HIV infection. So if there is an HIV infection and you have a TB choroidal granuloma, it's non-reactive. It will have a very minimal kind of fluid. Okay? Whereas in a healthy immunocompetent individual, it will be highly reactive, like here. Now you can see, now this granuloma, you can see the difference. It has both the components now. The component of the choroidal granuloma, as well as, now you can see it is a fluid which is collected in the subretinal space, because it is a reactive, it's a exudative granuloma. But something here tells me that there is a little bit of hemorrhages which is blocking, and there is an intense fluorescence here. Now this fluorescence intensity reminds you of retinitis. That means this choroidal granuloma is now going into the retina, pushing itself with the retina. Okay? So can we see this phenomena on OCT? We can't see. Just imagine for yourself. Why we shouldn't be able to see it on OCT? You know, these days we do what is called enhanced depth imaging. So you can see the choroid right up to the sclera. And with much greater resolution if you have step source OCT. But even the spectral domain OCT would show you with reasonable resolution the structural details of the choroid. So you can see the choroid, you can see the retina details. So if you have a choroidal lesion invading the retina, what you will see? This is what it shows. You can see now there is a huge elevation of the RPE, indicating that there is something pushing the RPE up there. What pushes them is choroidal granuloma. So you can see on the left side, same patient, and after resolution, it's gone back. It has come back to its original curvature. Here it's all elevated. Now you know that this here is affecting the outer retina. It is lifted, gone under the retina. There is a lot of fibrin here, the fluid here. So it is touching almost like the outer plexiform layer there. It's reaching into the retina. Okay, so you can follow it up with a scan, OCT scan. So I've told you now the fluorescein, the clinical, the fluorescein and the OCT, you can tell the difference. Okay. Now this, what do you make out of this? This is a quiz question. Very difficult. So have you wasted time? Half an hour of your precious time? It's a retinitis. Toxoplasma retinitis. Okay. So I also talked of retinitis going into choroiditis. The earlier example was choroiditis coming into the retina, posterior retinitis. So here is an example of retinochoroiditis, and you can see here it's not as intensely hyperfluorescent. There is a central hypofluorescence. Something is happening there which is blocking fluorescence. And when you do the OCT, now you see here that there is an elevation of the choroid. There is a choroidal thickening there. So, and you can see the neurosensitive retina is totally affected there, hyperreflectivity. You know, it looks homogeneous. There is no layers that you can make out of the retina. Okay, and when you follow it up, you know, as a heel, okay, you can see this lesion as it starts healing with a little bit of destruction here, and you can see the decreasing choroidal infiltrates. Now, what are the other signs? I said you see a lot of vitreous cells in front of the toxoplasmic retinitis or retinochoroiditis. Can you see them on OCT? You can see them. So these are the distinctive features. You can see these vitreous cells here, and you can see them, you know, sticking to the posterior hyaloid here. Sticking. This is a very unique feature which has been described by this group from Anirudh Agarwal from Art Center and Alessandro from Italy, from Milan. Okay. I think you have any questions still here? So we are trying to differentiate between retinitis and choroiditis and also discuss the management issues of toxoplasmic retinitis, which in some countries is the commonest cause of infective uveitis in the posterior segment. Are we all clear on that? Good. This is the time you can ask any doubts. Now, this is a patient, young man. Actually, he's undergone a renal transplant and he's on maintenance immunosuppressive therapy. What would be the typical prescription these patients would carry? Can anybody tell me that? What is the usual prescription of patients of renal transplant would have? Very difficult. Yes. So they are typically on maintenance dose of oral corticosteroids. They have also one immunosuppressive agent, you know, which is azathioprine, or you know, what is it, mycophenolate mofetil, and one of these cyclosporine, the tacrolimus. So these would be the typical prescription of patients who have undergone renal transplant, and these they have to take lifelong. So their immune system remains low. Now such a patient, now this is a young man, I think 24, 25 years, and when he came to us, if we didn't ask him, okay, and we have to ask him a question depending upon what we saw here. So anybody can tell me what we are seeing here? Anybody?
The father's photo shows the appearance of a granular type of infiltrates in the inferior temporal retina, not large hemorrhages, and the FSA.
So what I'm showing you is a one touch, and you can see these peripheral lesions, retinitis lesions. There is a media haze here, it is not clear, okay, and the other eye also is showing similar. These are retinitis lesions, okay. There is a haze over these. They are blurry margins, they are not sharp margins. And on angiogram, these are intensely hyperfluorescent. So we have discussed all these in the previous case. Now what we are seeing is the retinitis lesions are tiny, tiny, tiny. So when you ask him, so he comes out, well, I've had a renal transplant. Anything else? Well, I had fever, I had chickenpox. So patients who have history of immunosuppression, maybe renal transplant patients, maybe they are HIV patients, maybe they are, leukemia patients, maybe they are lymphoma patients. When they get infection like herpes zoster or chickenpox, you tend to get what is called acute retinal necrosis. So when we were still trying to debate, now if there is one emergency in posterior uveitis, this is the emergency. This is the emergency. You have to make up your mind. There is no wasting time to tell whether this is choroiditis or we can give steroids. If you give steroids, the fellow would be blind within no matter of time. Okay, so you have to make up your mind. So believe me, this is within 72 hours, the picture. So anybody can describe this?
So there is worsening of the...
Why don't you pick up the mic, sir? Just describe the lesions. I'm not interested in what is causing it. You just describe the lesions.
There's worsening of the peripheral lesions. They have now increased in size, getting more confluent, and spreading circumferentially, encroaching to the posterior.
Very nice. So that's how we have to develop our descriptive skills. Okay, and if you add it, what you are seeing here, what is the best description for this?
The arterioles are getting occluded.
Tongue shape. So these are tongue shaped lesions. Okay, so tongue shaped lesions, as they are extending posteriorly and circumferentially, right? The vitreous reaction would depend on your immune competence. If you are highly immune competent, normal, you'll throw a lot more reaction, as I said earlier. If you are immunocompetent, immunocompromised, you will have less vitreous reaction. Okay, so this is caused by which virus? VZV is the commonest, HSV is less common, but these are the herpes group which causes this infection. It's an emergency. Why it's an emergency?
Because it can progress rapidly without treatment and get overdone.
So if you did not take, and I'm not going to go into the details of treatment, okay, so you need to treat them very aggressively on intravenous antivirals, acyclovir or valcyclovir, and follow it up for 6 to 8 weeks with oral maintenance therapy, because these necrotic areas, they develop what we call sieve-like. When the region will heal, these are the full thickness necrotic areas. They will develop holes, breaks. So these are called sieve-like holes. It's very difficult to reattach this retina, and majority will develop retinal detachment. And not only that, there may be an interval of few weeks between the two eyes. And if you did not treat the first eye, the second eye also might get affected, and your patient may become totally blind. Right? So same patient, like he was treated here, and you can see the response to treatment is excellent. These patients respond to treatment very, very nicely. Okay? So we are talking here now of herpes infection. Specific situation here is a VZV causing, VZV causing acute retinal necrosis. Can OCT help us in diagnosing it? So here is again from the same paper, there is this information which is very interesting, that these are the hyperreflective strips which have been seen in patients which are not seen in any other necrotic retinitis except in these patients with viral retinitis, herpes simplex or VZV. And these are speculated to be the molar cells, and through which the virus is spreading from here into the retina. Anyway. So anybody can now make a spot diagnosis of this? The difference between the previous one and this? Reactive, non-reactive, immunocompetent, non-immunocompetent. Huh? Fawn, somebody said very rightly, this is a progressive outer necrosis. This is sieve-like. The retinal vessels are spared here, unlike the full thickness involvement of the competent individuals, immunocompetent, which cause acute retinal necrosis. Here, the lesions are a little deeper in the retina, okay? And look at the clear media. There's no vitreous haze here. There's no reaction here. Why there is no reaction? Because the person is immunocompromised. And we mentioned some of the causes of immunocompromise: HIV, patients of leukemias, lymphomas, or immunosuppressive therapy. So in this kind of situation, the prognosis is very poor unless you can make a very prompt diagnosis. Okay, and what infection you have to ask? HIV. Yeah, we did that. HIV. Huh? What infection is crucial in patients who are immunocompromised? You guys have shorter memory than me. Huh? So I said, ask them if they had chickenpox or what is the counterpart of chickenpox? Zoster. Okay, so I gave you an example of VZV causing acute retinal necrosis in a patient who was renal transplant on immunosuppressive therapy, and here is a patient who has no reaction in the eye except this opacification. Okay, he's a patient who is HIV positive, and in these patients, what infection would you ask? Chickenpox or zoster? And that's what it was written on his face. Okay, this you know. Huh? CMV retinitis. It's a very, very chronic, low-grade inflammation. You know, it keep on progressing. It's not something what we see in the other two herpes viruses. CMV is also herpes group, but this is the one in immunocompromised patients. So VZV, we have shown it can cause infection in immunocompetent individuals. It can cause infection in immunocompromised individuals. CMV in the posterior segment is invariably seen only in immunocompromised. Okay, so this is the hallmark of HIV infection, right? What CMV infection we might see in immunocompetent individuals? Anybody from Singapore? Anybody here?
CMV anterior uveitis.
CMV anterior uveitis is typically described from here in Singapore. Okay, so normally we do not associate CMV infection with the immunocompetent individuals, but in immunocompetent individuals, CMV can cause anterior segment inflammation and causes what is called, earlier we used to know as posterior syndrome. You know what is posterior syndrome? High pressure. So viral infections typically would cause what is called hypertensive uveitis. So you must check two things in these patients. One is the corneal sensations and the other is the pressure. So if you find a patient with high pressure, think of viral infections. Okay? So we are digressing a little, but you know, you will remember CMV in immunocompetent individuals. Remember Singapore, Dr. Soon Pek Chi. You will remember? You don't want to remember? Eh? You want to? Okay, good. So, does it have any characteristic features on OCT? Well, there could be, and this is what is described as these some kind of intraretinal pockets of fluid. Okay. The other feature is in these CMV retinitis patients. Now, why I'm telling you all these OCT characteristics is the reason is that if by clinical exam you are not able to make up your mind, you could use help of these ancillary investigations. Okay, so if you know some of these characteristics, like if you have to tell the difference between toxoplasma, I have shown you in toxoplasma involvement of the choroid, there is an elevation, there is a thickening of the choroid. Okay. On the other hand, in these patients, there is no involvement of the choroid. CMV retinitis stays in the retina without choroidal involvement. Is that right? You can see here is a full thickness retinitis and choroid is preserved. Now here is a quiz question. Is a young lady bilaterally affected? Any guesses? It has to do with the infections we have discussed so far. So can anybody tell me the infections we have dealt with so far? Yes, enumerate quickly. You, sir? Syphilis we have not discussed as yet. Come on. Huh? You're tired?
Toxo, tuberculosis, then viruses, VZV, HSV.
So which infections did I discuss? I discussed toxoplasma and viral infections, and I took example of TB just to show that it is in the choroid and it might come into the retina from behind, isn't it? Not primarily of the retina. So you think this is affecting the retina or it's affecting the choroid? What? Retina. Yeah? Anybody? Any other opinion?
Neuroretinitis.
Neuroretinitis. What is the essential qualification for neuroretinitis? You have to have optic disc edema. You have to have those exudates which extend right up to the foveal center. Okay, that's what we call neuroretinitis. All right. So we don't know We are seeing retinitis. Okay, now retinitis, again we discuss the immunocompetent or immunocompromised. So when you see infection of the retina, you want to know, am I dealing with a immunocompetent individuals or am I dealing with a immunocompromised individual? So what is the first test you will do? Come on, before that. You're right, in a way, CD4 comes a little later. Before that comes HIV reactive. Okay? Now if I tell you this patient was HIV positive, then this patient turned out to be HIV positive. So we are not able to make up our mind. This is not CMV retinitis for sure, because that's not seen as, what is the characteristic description of CMV retinitis, which I've just shown you.
Ketchup and cheese.
Ketchup on pizza pie. Okay, that's what it is. A lot of hemorrhages, vasculitis, hemorrhages, atrophy. It keeps healing and it keeps producing, keep progressing, those kind of. So it's a slow process, chronic process, right? Here it is more violent. You can see there is a reaction here, there is intense necrosis here. So if I ask you, is it toxoplasma? Can it be toxoplasma? Can it be viral? Possible. So some of these complex patients who are immunocompromised, you have to maybe go a step more than the conventional testing, like we did in this patient, a diagnostic, vitreous surgery to take out the vitreous fluid and see exactly why is it required to do this definitive diagnosis. Anybody tell me why we need to make a definitive diagnosis of infective retinitis? Come on. Why we need to make a diagnosis? Enteric fever or typhoid or malaria? Yes. So infections are controlled only when you are able to make appropriate, correct diagnosis. If you don't know what organism or what is causing infection, how are you going to give appropriate treatment? So this becomes a challenge, particularly in patients who are found to be immunocompromised. Immunocompromised means either immunosuppressive therapy or HIV or lymphoma, leukemias and all those, right? So in these patients we need to go a little more invasive, test, and I'm not going to show the pictures. She turned out to be positive for both VZV and toxoplasma. She was treated for both, and she actually returned absolutely fantastic outcome in this patient who was going to go blind. So I'm not discussing that. Okay, the outcome, the treatments I'm not discussing, so I'm not showing the follow-up picture. We can see it some other day. Now, anybody, I think Dr. Kwan was showing something similar, and he was asking a question I just overheard. What was the question he asked? Any one of you remember? Come on.
Last one is hard exudates versus autoimmune spots.
Yes, very smart. So he was asking, how do you tell it's exudates, or how do you tell it's cottonwood spots? Okay. So what do you think it is here? These are cottonwood spots. So some of these patches we call retinitis patches could be because of ischemia. There is occlusion of the pericapillary arterioles for a variety of reasons. Okay. could be partly because of the edema. So you cannot always say that no, it must be a cotton wool spot, because cotton wool spot itself may have retinal edema, infiltrates by the inflammatory cells, so there will be a component of inflammation. Now this is one manifestation of what we call dengue fever. You have dengue fever here? You get epidemics. These are vector borne. Dengue, chikungunya, and so on and so forth. There's so many of these are vector borne, mosquito bites. Okay, and many of these patients would come to you, okay, a few weeks after the fever, and they might, if you ask them, they'll say, okay, I've had fever, but a lot of people in my neighborhood also, in my building also had that fever. Okay, and they became all right, but I have got now blurring of vision, and you find this kind of picture, and you can give, these are all RNA viruses. There is no specific antiviral therapy except for controlling a little bit of inflammatory reaction in the retina by giving them oral corticosteroids, and you can see this resolved. But remember, the area which has become ischemic, where there is capillary shutdown or capillary non-perfusion, those areas will not reperfuse. They may not be clinically evident, but they will not be reperfused. So it looks artificially very nice, okay, but it will, perhaps it has, a permanent loss of those capillaries, which may be symptomatic or asymptomatic. That is besides the point. Now I'll show you another patient.
So
Yeah.
for that dengue retinopathy, that was dengue retinopathy. Will you then call it a cotton wool spot, or is it a focal?
I would call it retinitis. I would call neither cotton wool spot, nor I will call it exudation. I would call what it is a retinitis, which has developed most likely as an autoimmune. Dengue induces autoimmune reaction. There are several diseases which occur in dengue patients because of autoreactivity, autoimmune response. Okay, they can lead to precipitation of autoimmune diseases, right? So now this is a patient. You can see again a few hemorrhages, but depends upon the platelet counts, and the hemorrhages could be few, could be more. Hemorrhages, when they absorb, do they leave any deficit behind? Do you expect hemorrhages to leave behind deficit? No? Because of? Ah, come on, I don't know. This was taught to us long time back. Somebody said hemosiderin destroys the photoreceptors. No. Where is the photoreceptors in the nerve fiber layer? Is there a photoreceptor there? No. So, see, that's why I'm not bothered about exudates, I'm not bothered about hemorrhages, because these are the secondary phenomena. Wherever there is inflammation, there will be water leaking out, cells leaking out, proteins leaking out, RBCs leaking out, and you would have these hemorrhages, you would have edema. You take care of the primary pathology, they'll go away. They, by and large, do not cause any structural damage. Okay. So in this patient, the platelets were less than 50,000, okay, and his dengue antigen was positive. And this is what we see on angiogram. There's very little, just few hyperfluorescent. Okay. And this patient was actually reported by Dr. Amod Gupta and Dr. Bro in 2017. The interest was whatever those areas we were seeing, and the discussion was exudation versus cotton wool spots. What was it? So, do you know any technique by which we can now, without injecting any dye, can study the capillary network of retina? OCTA. So how is it better than fluorescein angiography? How is it better? Yes. So with fluorescein angiography, we could never be able to see what is called the deep capillary plexus. And deep capillary plexus again, has two layers. Huh? So we could never see it because the fluorescein would leak and would obscure all the details of the deep capillary plexus. So this patient, they did very clever. What they found was, well, in that area there is a capillary dropout, non-perfusion in the area of that lesion that was very subtle, yellowish, looked like aggravation. I would call it retinitis. But more importantly, they found in the deep capillary plexus, they found there was capillary non-perfusion. Okay, they very recently they have described what they're calling dengue-induced inflammation ischemia, and this paper, I don't know, Vishali, this paper has already come. Or ophthalmology retina, you should look up this paper when you are dealing with dengue retinopathy here, very commonly in this area. So this is what is coming, where you can see this conical protrusion of the, so it's a dengue-induced ischemia and inflammation. So they call it DII foveolitis. So neither it's cotton spot nor is exudate. Is what they have termed now is dengue-induced inflammation ischemia and inflammation of the fovea, so foveolitis. You get it? And this patient responded very well. Now, I have finished 1 hour of my time. Okay, so we don't want to hold you back. So I just want to show you a quiz question. Now this guy is 38 years and he's had dengue, fever, treated elsewhere with intravenous infusions, sportive therapy. His platelets had dropped down to 30,000 per cubic millimeter. And now he says, well, for last 15 days, I'm not seeing well from the left eye. Yeah? Does it look like what we have seen in the previous patient? So, do you think this is dengue-induced inflammation, ischemia, foveolitis?
This looks a bit pale and porous.
So, an angiogram was done for this patient. I don't think they did the OCT angiogram on this patient, but regular fluorescein angiogram was done, nothing found. So, what test would you order for this patient? OCT. Very nice. So, all of you have the consensus, we must do the OCT. And let's see how many of you would interpret this OCT. So you have right over the foveal contour, you have this intensely hyperreflective deposit. Is it affecting the retina? Anybody can tell me what other tests would you like to do to get at the bottom of what is this lesion? Because the fellow is not seeing. He's going to chase you if you don't give him the answer. What is this? Is he likely to improve vision? Is he not likely to improve vision? Is he going to go blind, or is he going to see normally? These are the questions which are bothering the patient and should bother you as well.
What is the EA? What is
624.
ERG?
ERG. Wow. You know, ERG we also bought with great fanfare. I don't think in clinical practice anybody except those die-hard electrographers or whatever you call them would do ERG. It doesn't give you anything. I never learned anything from that. Okay. Fluorescence, which? Autofluorescence. Why? You are genius. I must say that. How do you interpret this now? Fantastic. This is fantastic. You are sir ready to take my place here.
I mean, is this hyperautofluorescence?
This is hyperautofluorescence. So what is it?
If it's blood,
It's related to blood. So what is the autofluorescence properties of blood? So what happens to the blood? Blood is red. Okay. So what is the autofluorescence property of a red blood?
if it's red, it blocks. It's hypoautofluorescence.
It is what we call, it quenches the, if you are doing blue, in the blue wave, you know, it will be absorbed by the red blood. Okay, so what you will see is hypo. So if this guy had come maybe shortly after he became symptomatic and it was still red, okay, it would show hypoautofluorescence. Once they lose the hemoglobin part, the heme goes, now what you have is only this gray altered blood, what we call, okay, gray blood is collection of RBC shells. If you put them under microscope, they'll not have any hemoglobin, they'll just the outer shells of RBCs, and they become hyperautofluorescent. So you should always use these tricks that are available very easily. Now once you have made this diagnosis that this is a blood, what do you think will happen to this patient? What treatment you give? Yeah? Absolutely. So we must know, not only we must know when to intervene and treat, but more important, we should know when not to treat. So this guy was treated with nothing. And you can see he was told to come after a couple of days. He's improving one line. And why is it important to call them frequently? Because they are in panic. My vision is lost. I want to know whether I'm improving or not. He comes 2 days later. You show him one line improvement. He's very enthusiastic. My vision is going to come back. Okay, you will become a hero for that patient. I can tell you that. So that is here the situation is. The patient returned 3 weeks, 8 days, 6 vision, doing nothing. And you see how it's changed? Great. Thank you so much. I've overshot little. So what will happen to the autofluorescence? Yeah, it will stay or go? It will?
You should go.
It should go. So it did go. So well, thank you. I think I can go on for another couple of hours.
Thank you, Professor Gupta. I think he's trying to stimulate you post-lunch. We can imagine all of you are full with thing. But and then we made a dark room also, a perfect ambience to sleep. But still trying to wake you up with all these questions. I think there is a lot posterior uveitis. If he's learning at his still age and still takes every case as a new challenging case, so I think all of us have a lot to learn, big journey, right, Professor? You still, I think every case teaches.
Have time in the afternoon during the case discussions. We can have some of the others.
Yeah. So we are having few cases lined up where they can share some of the cases of the posterior uveitis. I think.
So this one is one third of the lecture done.
1/3 of. Anyway, so we'll move on to the next topic, which is on the VKH and